Family Division of the Potocsnak Family Division of Adolescent and Young Adult Medicine. I'm Julie Kalkbrenner, and I'm one of the liaisons here at Lurie Children's, and I cover the western suburbs, and I'm joined by my colleagues, Chad Worley and Paula Nowak this morning. In this session, we will introduce you to Dr. Gregg Montalto, and he will discuss psychotropic medication management. Let's see. Go down this slide. Oops. This here is a picture of the Potocsnak Family, the Family Division of Adult and Adolescent and Young Adult Medicine. This center provides care for ages 12 to 22 years, and all patients are followed until their 25th birthday. In the photo you see here is Lurie Children's Outpatient Services at 440 North Dayton. For those of you that are not familiar with our new RAMP website, RAMP is a mental health care reference, resources, and curriculum for pediatric clinicians. It is formed by a group of mental health specialists partnering with pediatric clinicians to expand access to mental health care. This is easy to access. Just type in ramp.luriechildrens.org. We've got about 13 different conditions in there for resources for providers. And lastly, I'd like to remind you all that we respect all as a commitment at Lurie Children's. We are relentless in our pursuit of a healthier future for every child. We exist to help all children reach their fullest potential. Lastly, I would like to remind you that this session is being recorded. We encourage you to type your questions in the Q&A section. Due to the large audience we have this morning, we will not be unmuting the audience to take live questions. Now I would like to turn it over to Dr. Montalto.
Thanks very much, Julie, and thanks everybody who is joining. I think you need to, there we go.
Sorry.
There. All right, are we good?
Perfect.
Okay. Okay. So I am Gregg Montalto. I'm one of the faculty at Lurie Children's Hospital in the Division of Adolescent and Young Adult Medicine. I have been here at Lurie Children's for about 2.5 years, in the Chicago area for a little more than 4 years, and have found that certainly this area, and related to the pandemic, of course, that the need for adolescent mental health care has just grown exponentially. And it's something that can be done in a primary care setting for the majority of patients. And so just want to talk about psychotropic medications in their basic form. Due to the timing of this, I want to go about 20 minutes and leave enough time for questions, because I know that I can't predict what everybody might want to know out of this. And the other thing that I did with this talk is I'm really going to focus on medications for anxiety and depression, and I'm going to leave out stimulant medications just for the purposes of time, but I'm happy to answer questions about stimulant medications or medications for ADHD if they come up. So I wasn't exactly certain how to put this together, and realized that the best way to talk about this quickly is to do things that I do in clinic. And a lot of times when I am working with residents, I'm working with fellows, we have these conversations with parents, and through doing the parent education, we can learn a lot about the use of psychotropic medications. So we're going to binge watch 6 seasons of psychotropic medication management in the adolescent clinic, and you'll catch on hopefully here soon. So here's the situation. So in 2009, the American Academy of Pediatrics came out with their policy statement saying that primary care clinics should be able to take care of some of the basic depression, basic anxiety, attention deficit, And, they also say that, here, knowledge and skills of evidence-based therapy, psychopharmacologic therapy, and skills is, integral to pediatric care. They also acknowledge that, like, oh my God, nobody really knows how to do this, and we're going to have to provide support for that. And then the 2019 policy statement just essentially reaffirmed that. So this came out a little less than a year ago in MMWR, and I'm sure that you guys have experienced this in your clinics. During the early parts of the pandemic, more than a third of kids experienced poor mental health. Almost a third had experienced poor mental health in the preceding month. And you see there that there were almost 20% had considered suicide and 9% had attempted suicide. Those are astounding numbers. And, there is absolutely a huge deficit of psychiatry in the United States in this area. There are not enough therapists. And so in primary care, we do need to play a role in that. So prescribing, there are variations in prescribing throughout different practices. Looking through a large number of EMRs and healthcare systems, there is substantial practice variation. And so some of you might be like, oh yeah, we do this all the time, it's pretty good. Or we have a pretty big practice and we know that there are 2 or 3 people who are comfortable in doing this. And also found that this is not necessarily related to the availability of psychiatry therapy. So want to use this opportunity to make sure that people can become comfortable. So chief residents, this was in academic pediatrics a couple of years ago. And even, this is more than a decade after the AAP said, hey, you know what, we really need to be doing a better job in primary care, taking care of patients for mental health needs, including psychotropic medications. And after a decade, there was not much that had been done within the graduate medical education sphere to teach people how to do this. And a lot of people felt discomfort. There was discomfort, particularly around discontinuing somebody's medications, and more comfort with stimulant medications, which is another reason why I left this out. Okay. So the initiation, kid comes in, 16-year-old, you'd been seeing for his entire life since birth, just says, I am feeling a lot more anxious than I was before. I can't relax. I can't sleep. I haven't been able to go to school. I can't take exams because I'm freaking out about my exams. I sit down for my exams and I just can't focus on things. I have the SATs coming up. I have I'm worried about colleges. I can't fall asleep at night. His parents who are there at the visit say, you know what? He's like a lot angrier. He goes off all the time. He's angrier at his siblings, just on edge. And, this is not our son. I don't know what's going on. You take him separately. You want to make sure that there's, hasn't started, vaping, smoking weed, doing anything that might affect sleep, that might affect anxiety. Not suicidal, otherwise healthy, not on any other kinds of medications. So this is where, as a primary care provider, you can do a lot of good. You've collected this detailed history. And if we look at what the standards are for management of psychotropic medications, we need to have a detailed history. And you've done that. You want to make a reasonable diagnosis. Does it need to be specific? Do you need to know, is this like social anxiety? Is this a generalized anxiety disorder? That's less important than just saying, hey, you know what? This is anxiety. This kid is anxious. And remember that anxiety and depression have a lot of commonalities. And so if you are used to having kids fill out a PHQ-9 and they score pretty high, that doesn't necessarily mean they're depressed. They might be anxious as well. So knowing that this kid is anxious, knowing that this kid is safe, from self-harm and things like that is important. And so, you have a history, you've made a reasonable diagnosis of anxiety. And so now it's time to develop the psychosocial, psychopharmacologic treatment plan. And what's going to go into that? What psychotherapy resources are available to the patient? There are some patients who, they are well resourced. They might have had a therapist before. They might have a sibling who had a therapist, who has a therapist who they can go see. Their insurance might be good and might cover it, or they might have crappy insurance where it's not going to cover psychotherapy as readily as some of the other insurance plans. Or you might live in a place where there's just a huge dearth of therapists who can work with adolescents for their anxiety, for their depression. So it's important to discuss that with the patient and the family. What are the family's thoughts? What are the patient's thoughts on psychotropic medication, since this is what this talk is about and what the conversation will be about? Do they have any hesitations for it? Do they have any experience with it? Does anybody else in the family take any kind of SSRI or SNRI, which oftentimes will make people a little less anxious and a little more willing to have that conversation. Talk to the family and what the data says about psychotropic medications and anxiety. And that is that, for moderate to severe anxiety, it helps. For kids who have symptoms that seem to be consistent with obsessive compulsive disorder, it helps. And so it's very, very reasonable to consider using psychotropic medications, specifically SSRIs and SNRIs, in a patient who is anxious. For a patient who is depressed, moderate to severe depression, there was a big study, the Treatment of Adolescent Depression Study, or TADS, that was done, it was over a decade ago. And they looked at adolescents and had essentially 4 arms. There was, we are going to provide medication and provide psychotherapy. There's an arm where they say, okay, we're just going to provide medication. There's an arm where they say just going to provide therapy. And then there is where it was just, treatment as usual, just giving patient education and not doing anything like, a quote unquote placebo, even though it really is not technically a placebo. And so what they found was that there was sustained, and this is for moderate to severe depression, there was sustained benefit in the dual mode treatment arm. There was sustained benefit in the medication treatment arm, but not in the psychotherapy arm. And so, particularly for families who have difficulty in accessing therapy, medication is a reasonable option to discuss with them. What medication should I use? What dose should I start with? What are the side effects that I should discuss? And then how often do I need to follow up? And the prior 2 questions we are going to discuss in subsequent slides, but how often do we need to do follow-up? Early on, kind of frequently. I mean, if we're going to start somebody on a medication, we want to check in with them within a week or 2. And that does not need to be an in-person visit. That can be a phone call from a social worker in the clinic or one of the nurses in the clinic, and just say, hey, how's everything going? How are you feeling? Are you noticing any side effects? By that point, you're not really going to notice any benefit from it, but just to check in and see how things are going. And then as somebody hits kind of a maintenance where everything is going well, hopefully, and, kids are like, back in school, this 16-year-old is back at school, back able to take exams, not worried about the SAT anymore, sleeping better. You probably only need to see him a few times a year. It doesn't need to be every month in order to provide quality care to a patient with anxiety. So what are our choices? SSRIs and SNRIs are effective for anxiety disorders, major depressive disorder. And so they are something that we definitely can consider in our adolescent and young adult patients. Certainly want to make sure that we are screening for any kind of mania or hypomania. And that's not this kid who just has become more agitated and has difficulty sleeping. We have this tendency to associate, oh, they're not sleeping at all. Maybe they're manic. And you just ask, like, are you tired all the time? Yeah, I can't sleep and I'm exhausted. I want to sleep and I cannot sleep. That's not mania. A kid who goes out and does a few stupid adolescent things, gets, drunk at a party and, maybe gets picked up by the cops at a party. If that's not happening recurrently, if they're not, doing things that are above and beyond, normal dumb adolescent behavior, which, we're all adolescents. We had all been adolescents at one point in time. We have all done dumb things in our lives. But if they don't cross that line, then, it's reasonable to use one of these antidepressant or anti-anxiety medications. There's no real good evidence to support one over the other. Something that comes up a lot is, well, what about genetic testing? I did this genetic test, or a friend did this genetic test, and they said that, sertraline is the best medication. Genetic testing it's garbage science at this point. If somebody has already done it, I don't say, oh, I wouldn't have done that. But if somebody asks if they should do it, I'm like, no, it's not worth the money. Your insurance company is not going to pay for it. And the science is just not there to do that. So, what medications do we pick? The left column there, fluoxetine, sertraline, escitalopram, those are selective serotonin reuptake inhibitors, or SSRIs, that are pretty commonly used. Citalopram and paroxetine are two other SSRIs, and I cross those off for a few reasons. One is paroxetine has an increased risk for adverse effects in adolescent patients, and I cannot remember the last time that I have prescribed it. Escitalopram is one of the stereoisomers of citalopram. Citalopram has it is a QT prolonger, and just because I don't want to worry about, is this kid going to wind up in an emergency room and throwing on some Zofran or something else that's going to prolong the QT interval, just don't really want to mess around with that. And so I generally am not picking those two, but of the other three, there are, benefits to some of them. Escitalopram has a quicker onset of effectiveness. And so, like, if you're looking to get something done pretty quickly, you can get to a therapeutic dose a little bit more rapidly than with fluoxetine or sertraline. Fluoxetine has the benefit of having a long half-life, so that if you have somebody who might not remember to take their medications every day, it might be a better choice just because it's a little more forgiving for missed doses. And then on the right column, venlafaxine, desvenlafaxine, and duloxetine are SNRIs. Also can be used for anxiety, can be used for depression, and work well in adolescent patients. So here's something that comes up quite a bit: the refill. The kid comes in, 14-year-old kid, recently discharged from an inpatient psychiatric unit, needs a refill, on wait list for psychiatry, on wait list for therapist, taking escitalopram 15 milligrams daily, has passive suicidal ideation. And so what do you do? And really, we all feel this way. You're stuck between a rock and a hard place. And, my own personal practice is that, you want to make sure that the medications that they're on are reasonable for what their diagnosis is. You want to make sure that you start the process of ensuring that they do get psychiatric follow-up, that they do work with a therapist, and that they are brought into some kind of psychiatric medical home for treatment. And the other thing is that it's, there's harm in not refilling kids' medications as well. And so I generally tend to say, okay, we'll do your refill. We need to start working you into clinics. But we definitely don't want to stop medications in somebody who has been suicidal, who might be responding to a medication, and stopping that medication might increase their depression and suicidality. Side effects that I talk about, first of all, I ask patients to please do not read the side effect list, because you will feel, especially people with anxiety, will feel like they're having all of them. If they start feeling something, they can certainly look to see, is this a possible side effect of the medication? But there are so many different side effects that I don't advise reading the side effect list. So these are the common ones and things that I talk about before starting medication. A lot of people feel a little nauseous or get a little diarrhea. We have more serotonin receptors in our gut than we do in our brain. And when they start to get, fired up, then it can cause a little bit of nausea. It typically lasts a week or two. With starting a medication with a dose change, gets better. Changes in sleep. This could be I sleep better, I sleep worse. Just to look for how they're sleeping. A little bit of activation, jitteriness. It's like having, a few cups of coffee in the morning. Some people just feel more shaky and jittery if they do that. Some people drink a cup of coffee after dinner, they can't fall asleep. Similar kind of feeling. Headaches can happen. Sexual dysfunction can happen. And, and yawning, which I put on there, not because it's a common one, but just because I just find that one interesting. So changing medications also is something that we're faced with. Why do we change medications? Maybe a medication isn't working. Maybe somebody is experiencing a side effect from a medication. First of all, we want to make sure that they've had a significant or a reasonable amount of time before we say this medication isn't working. If you start sertraline, the dosing range is typically 50 to 200 milligrams for depression and anxiety. And if you take 50 milligrams for, a month or two, that's not a good enough trial. You need to increase the medication as long as they're not having side effects until you start to see effects. We don't want to change medications too frequently because it just is. A, we don't need to. B, people lose confidence in these medications working, and then subsequent medications might not be given a long enough trial. And changing medications is part science and part art. I put the half-lives up here because there is no best or worst way to go from one medication to another. If you are transitioning from one SSRI to another SSRI, you can cross titrate if you want. I find that is kind of a pain to do. And so as long as you have two medications in the same class that have a reasonably similar half-life, I'll say, okay, you're on 15 milligrams of escitalopram, dosing range is 10 to 20. That's middle of the range. And we're going to switch you to sertraline, has a similar half-life. And so I'm just going to stop your escitalopram and I'm going to start you on sertraline at a similar dose and, in the range. And so for sertraline, I would go from 15 milligrams of escitalopram to maybe 100 milligrams of sertraline and just say, stop this one today, start that one tomorrow. And it's just a lot easier to do it that way. The caveat to that is look at fluoxetine in the half-life. It's long. So you have to let that one wash out of the system before you really get to, a quote unquote equivalent dose. So if they're on a high dose of fluoxetine, give it time to wash out of the system, start at a really low dose of another SSRI. When transitioning from an SSRI to an SNRI, I usually do a bit of a cross taper, but it doesn't have to be a substantially long cross taper to go from one to the other. A week, 2 weeks, start going down on one and going up on the other. And then obviously we need to check the formulary when picking medications because, the insurance companies make too many decisions for us. And then finally, just wanted to talk about the black box warning because this has gotten in the way of people prescribing medications. It has made people anxious about prescribing medications even when they do. And so I always talk about this with families and I use it as an opportunity to talk about suicide as a group with parents in the room, with kids in the room, so that suicide isn't, kind of this secretive thing that we don't talk about with our parents and with family. So in 2004, the FDA reviewed 372 randomized clinical trials with about 100,000 subjects. In the treatment arms, there was a 4% prevalence or incidence of suicidal ideation or behavior. Placebo arms, it was 2%. So they're like, okay, it is statistically significant in patients under the age of 18. And so we need to put out this black box warning, which they did. There were no fatalities. Important to say to parents, nobody died of suicide in this study. So what does that mean? It means that people got scared and there was a decrease in the amount of, or the amount of SSRI or antidepressant medications that were prescribed at that point. And it didn't recover, at least by 2014, when they looked back at the 10-year anniversary of this black box warning. So I talk about this with families. I'm like, look, there may be a chance that these thoughts of suicide pop into your head, or these thoughts of suicide are increasing. And it may or may not be because of starting on an antidepressant medication. But what I want is for you to know that if this happens, who are you going to reach out to? Who are you going to talk to? And I have this conversation with everybody in the room, unless there's a reason to not have everybody in the room for confidentiality reasons, because it's, even if there's not an increased risk for completed suicide, it still kind of freaks people out when they're having thoughts of suicide. So I always talk about the black box warning before starting it. And I reassure parents that, look, this is the right thing to do for your child. I want you to be comfortable with it, and I want to be able to answer all your questions. Okay. I probably went over looking at my time. Shit, I did. Oh, sorry, I did. So let's look at some of these. How do you know when anxiety about SATs in college is within normal, or when it needs to be treated with medication? That is an excellent question. It takes a conversation. Like, if it's different than what it used to be, if they are unable to function. And I talk about anxiety, totally different topic that I love to talk about. But when I talk about anxiety, there is, anxiety is not bad. Anxiety keeps us studying for exams like the SAT. Anxiety keeps us checking our blind spots so that we don't hit a cyclist before we make a right turn. I mean, there are good things about anxiety. When anxiety affects our function, when it affects our happiness, then it might need to be treated with medication. And so really it's, for everybody, that threshold is a little bit different. But yeah, being anxious about the SAT is not a big deal. For the kid, the kid in the scenario in this talk, it was a big change from where he was before. Is there a standardized questionnaire you should be using for anxiety? We use the GAD-7, what is Global Assessment for? I can't even remember what it stands for. Somebody put in there, Jess put in there what it stands for. The GAD-7 is a reasonable screener. It's built into Epic, and so you can assign it to patients before the appointment through MyChart. They can fill it out. And again, it's a screening test. It's not a diagnostic test. There are more extensive anxiety tools that we can use, but for the most part in primary care, I think a GAD-7 is a reasonable one. Oh, thanks, Jess. I see her putting in the answer. Some kids have chest pain and difficulty breathing with anxiety. What and when you start a cardiac workup, and what test before any treatment? So, excellent question. So it's the same kind of workup that we will do for any kind of chest pain. If somebody says, I have palpitations and they're very, very clearly related to their anxiety. It's still not unreasonable to get an EKG and make sure that they don't have, Wolff Parkinson White or something that is going to potentially throw them into an arrhythmia that they might feel. If it is, if they have these symptoms at rest, that is always very reassuring. So I don't do an extensive cardiac workup. I just do enough that, they're complaining of chest tightness, they're complaining of palpitations. It is very, very much related to their panicky symptoms. They have a normal EKG. And to me, that's plenty. The black box warning. These were studies where it was being prescribed for depression. I have the same talk with anybody, even if they are being prescribed an SSRI for anxiety. I still have the discussion about the black box warning for a couple of reasons. One is that you can be anxious and depressed at the same time. Number two, sometimes, like I said, the symptoms of adolescent depression and adolescent anxiety, it's a Venn diagram with a reasonable amount of overlap. And so I'll always have the black box discussion, but the data that the CDC reviewed was looking at patients with depression. Any comments on hydroxyzine? Hydroxyzine is not a bad medication for somebody as a bridge to get them to an effective dose of an SSRI. So let's take that 16-year-old patient. Parents, kid, they're like, yep, you know what? I am all about starting sertraline. So let's do that. We know that it's going to take a month or more for them to actually notice any effect. And so what are we doing for the symptoms now? And hydroxyzine is, it can be used for anxiety. And there's actually a broad range of dosing for anxiety. For allergies, we use it, like 10 to 25 milligrams 4 times a day. For anxiety, sometimes we're using 25, 50 milligrams. You can use up to 100. It's really rare that I do that. But it's a reasonable choice for, kind of either an as needed or a standing dose for somebody who needs to be bridged because they're just not functioning particularly well until you find out whether or not the SSRI is going to be helping. Screening tests that are favorites for depression and anxiety within a primary care visit. I like the PHQ-9, modified for adolescents, and I like the GAD-7. Both of them in the Lurie Epic system are built in, and they can be assigned before the appointment so that they can be reviewed. And then once they're filled out, you can trend things and, see how people are feeling over time. And it is something that can be done while the patient is being roomed. And if you're like me, I'm running behind. And so it gives the patient something to do rather than wonder where I am. How do I screen for mania? I just ask, like, do you have any difficulty with your sleep? And if they say, yes, I have difficulty with my sleep, then I drill down a little bit more. What does that mean? Like, if you don't sleep at all during the night, are you sleeping all day long? Do you have difficulty staying awake in class? And if they're sleeping in class because they can't sleep at night, then, that being up at night is not mania. Is it, somebody who is having high risk sexual encounters, a big change in substance use where they really weren't using a lot of various substances, and all of a sudden that's all that they can do. Spending is another big thing. Feelings of grandiosity is a big one. And so I mean, really, those are the things that I kind of ask. And you can just by getting the history, normally you've answered most of those questions already without asking them specifically. But yeah, no, if I need to ask them specifically, if I need to drill down, I absolutely do. Um, so are meds more effective than therapy long term for anxiety? So um, both can be effective. And this is one of the sad things about the state of medicine in America. And that is that access to therapists is not guaranteed. It is dependent on what insurance is. It is dependent on what the family's means are. It is dependent on whether or not parents are able to get their kid back and forth to therapy appointments based on their work schedule. And so there are a lot of things that go into whether or not therapy is feasible. Even though I recommend therapy, I'm not saying don't do therapy. But the reality is that a lot of times therapy is not a feasibility for long-term treatment. And certainly in the early stages, it's not readily available. Um, so for the most part, when we're dealing with various forms of anxiety, moderate to severe anxiety is best to be treated with both psychotherapy and medications. If you cannot get a patient into therapy, then using medication alone is a reasonable option. And for the most part, for kids with moderate to severe anxiety, you know, psychotherapy can be helpful generally. And this is my anecdotal experience. It's usually not enough. And I try to get kids both in therapy and on medications. Um, how long should you keep on meds? And then, when do you try tapering? That's an excellent question. And it's something that I do bring up with families and patients when we're starting medication. So if we are going to start this medication, I would like for you to give it at least 6 to 12 months before making a decision as to whether or not it is the right thing for you. And why is that? Because, moderate to severe anxiety, moderate to severe depression, it's not going to go away rapidly. So I want to make sure that everybody is invested in doing a trial of medication. Um, so 6 to 12 months is kind of my default. And then when do you consider tapering off the medications? That it depends on a lot of things. One, does the patient want to stop taking medications, or is the patient like, you know what, I feel really good, I don't want to change a thing? In which case, we can keep taking them for as long as they feel that they are effective. I think that that is a reasonable answer. If we're thinking about tapering, we want to make sure that there's not something that is upcoming that is going to potentially trigger depression, trigger anxiety. So, high school senior has been doing reasonably well with their anxiety, after getting past all of the SATs and the college applications and the FAFSA applications. And like, you know what, I feel pretty good. When should I wean? And some of that comes down to, do you think that you're going to experience anxiety because you go away to college and you're going to be in a new environment? And even if it's something that we're excited about and it's a positive thing, sometimes those positive stressors can tip us over the edge too. And so it depends on what is upcoming. And so some patients who have been anxious in the past and they've done well with medications in the past, they'll come to me and say, hey, you know what? Thinking about, do I need to go back on medications because my family is moving cross country and I have to go to a new high school, and I think that that might, make me pretty anxious. So what should I do? Pre-workout drinks. Yeah, don't get me started on that. So the caffeine, and I have worked with a lot of patients who use these pre-workout supplements that have ridiculous amount of caffeine and caffeine-like substances in them. And absolutely, people can show up anxious. They can have headaches, they can have high blood pressure, but anxiety, absolutely, they can do it. So if they say, oh yeah, I'm in the gym all the time and I use NO Explode and I use twice as much as I'm supposed to because I want to get huge, then yes, I would say, maybe this is why you're anxious and maybe you need to cut back on that a little bit. And then I think the last question I answered about how long to stay on an SSRI. So thanks for allowing me to go over. You can absolutely reach me by email. You can reach us through Epic inbox messages. However, it's best if you want to spend a little bit of extra time, saying, hey, I would love to kind of see what you guys do and maybe shadow some patients and stuff like that. We've done that with other people before. So, we're happy to welcome you to our clinic to see how we do things. Just let me know.
Thank you, Dr. Montalto. That was a great talk. Excellent answering of questions as well. We appreciate that. Also, the division is available through Lurie MD, our physician-to-physician consultation service. RAMP is an excellent resource as well. There's a section on there on the psychotropic drugs and management. Those curriculums are perfect. They're like 10 to 15 minutes each section within a curriculum. So I just want to thank everybody today and remind everybody we have session 4 today at 12:30, and Dr. Lance Nelson will be discussing eating disorders. Enjoy your morning and we hope to see you this afternoon. Thank you.
Thanks, everybody.
All right.
Hey, Julie, you still out there?